we want to be our staff's hero. We want to make sure that we're taking care of everybody. Like as an ER leader, and I'm sure you've experienced this, but in the wake of COVID, especially, like you can't sleep at night. You're worried about your staff. So I don't want to be laying in bed worried about my staff getting hit or some kind of acts of violence and them needing me to come in and help mitigate whatever is going on. They should be able to address it and be safe whether I'm there or not. So I don't want to be the hero. And we shouldn't all rely on one hero.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and thanks as always for downloading this episode and for listening to the podcast. I just wanted to take a minute and remind you, if you haven't done so already, please leave a rating and review for this podcast. That's how other people will find this podcast, is by your ratings and reviews. So if you haven't done that, please do so. Don't forget to follow me on social media. Follow me on Instagram. You can follow me on Facebook. My YouTube channel has all the podcasts right there in the YouTube video that you can check out right there. My guest today is a longtime ER nurse, former military nurse, and newly minted PhD. She is an amazing nurse, an amazing advocate for her staff, and I knew for sure that I absolutely wanted to have her on the podcast, and we finally got it together, and here we are. You are going to love this episode with my friend, Dr. Seliena Corrington.
I am Seliena Corrington, officially Dr. Corrington. I have been a nurse for 17 years now. I am absolutely a late bloomer. Believe it or not, I am a high school dropout. I dropped out my sophomore year, and I was 25 before I went back and got my GED.
Wow.
And so I have been a perpetual student since then.
How funny. So you dropped out of high school, went back, got your GED, not till you're 25. And then look at you
25.
now. You have the terminal degree for your profession. How cool is that?
Oh, terminal. It sounds horrible. Yes.
No, that's good. No, that's good. That means you're done. That means you're done.
I don't know.
You want to be done. That's good.
Constantly pondering what's next.
I got to tell you, I know multiple people who are, who have their doctorate and are now going back and doing their MBA. And
really?
Yeah. And I've asked, the second person told, 2 or 3 people told me that they've done this. And I was like, why? And they're like, well, because I don't have that skill set. And if I want to be in the boardroom, if I want to be, if I want to be the CNO, a DNP or a doctorate, it's okay. But they're like, if I want to be the CEO, I need that MBA.
Oh,
And I was kind of like, I don't know that I would do it. But I know 2 or 3 people with their doctorate that are going back and doing MBAs, and I was quite surprised. I was like,
wow.
Sure.
Yeah. My hat is off to them. I definitely don't want to wear a suit and sit in a boardroom.
No. And that's exactly what they would be doing. And I'm trying to think, I think they're both they're kind of doing that now anyway. They're both kind of more on the executive level. One for sure is, she's like just below the CNO at the facility, and then, is looking to take over the boardroom, probably take over the CEO spot and CNO spot. I have a friend who has his doctorate, and he did his DNP, and he's now a COO.
Oh, wow.
But yeah, so
That's really cool.
there's always people who are gonna go back and do more, and that's cool. But from high school dropout to now Dr. Corrington, how cool is that?
That is cool. I feel good about that.
So what was the trigger that you said you were 25 when you went back and got your GED and decided you were what made you say, okay, I gotta get back in school and get this together?
So I actually, which probably leads to ultimately my dissertation, I come from a lineage of violence, family violence. I was married at 16. There was violence in the home, and I had 2 children very young. And ultimately, I had to get out to save myself and my kids.
Wow.
And that started the school journey.
Holy cow. You were like, okay,
Yeah.
I got to get it together.
Yes, I remember very clearly the last time he hit me saying, "Go ahead, because when I graduate, I'm leaving." And I
Wow.
did just that.
Holy
Yeah.
cow. That's crazy. Now,
Yeah.
why nursing?
I always wanted to be a nurse. So you read your childhood books where you write every year, what do you want to be when you grow up? And I think there were a couple years where it probably said singer, um, maybe ballerina,
Oh,
but
me too. Me too.
there were definitely more spots that said nurse or doctor. Um,
Interesting.
yeah,
There you go. Check
yeah,
check both boxes. So
yeah, yeah.
good for you. That's awesome. Very cool.
I love people. Nursing is the best. I definitely picked my field.
That's great. I mean, I love it when I hear people say that, when they say they love what they do and still love what they do after, doing it for, 17 years or whatever. Um,
Yeah.
that really makes it better. So,
Yes.
so for sure,
Oh.
for sure. So, well, cool. What made so at what point did you decide you wanted to be an ER nurse? Why ER?
Oh, well, I'm an adrenaline junkie. ER was there was never I don't remember there ever being a question. ER
Mm,
was always what it was going to be. Do you remember that show? I think it was called ER, and it had Dr. Green in
yep,
it, and
yep.
I grew up idolizing them and like, yes, I am going to do that.
That's
Um,
cool. That's really cool.
and right out of nursing school, I was blessed to get taken into an ER, a trauma facility. And at the same time, right as I was graduating college, I was working on my paperwork to go in the military.
Oh, okay.
Yeah. And it took long enough because the Air Force just takes forever to get into that. By the time I got my acceptance, I had been a civilian ER nurse for almost a year. And
Nice.
they said, okay, we won't make you come in as a labor and delivery or med surge nurse. You can come in as a trauma nurse.
Awesome.
Um,
So
yeah,
so you joined the military and you were a nurse in the Air Force as well?
I was. I was a trauma nurse in the Air Force. So you get identifiers when you're in the service. And you could be an ER nurse without being a trauma nurse. Trauma nurse was a smaller sec. Um, So I was a trauma nurse, got what we called the J identifier,
Which
got a lot of
means
extra trauma. You
trauma. Okay.
specialize.
Okay.
Yep. Yep. I started out in San Antonio at Lackland Air Force Base, did a tour in Iraq for 9 months, and then got to do a stint in Europe. So I was in Germany.
That's
Um,
cool.
yeah, really good experience.
Good, good. So you joined the Air Force, got to be an Air Force trauma nurse, got to go to
Yes.
Europe. How long did you stay in Europe?
We were in Europe for 3 years. And
Working years there as well?
yeah, I was at Landstuhl Regional Medical Center. So we get all the troops from downrange there. So
Okay.
it's as close to being deployed, I guess, as you could be. But there is where I got into sexual assault forensic nurse. Well, it became forensic nurse instructor because at that time, Don't Ask, Don't Tell was repealing, and they took sexual assault away from nursing in general, and they gave it to physicians. They wanted them to do the exams. So that led to my first instructor gig.
Wow. Very
Yeah.
interesting. Interesting. And and I mean, I could see that as being something potentially like a specialty of a specialty, especially in the military. Like that's a
Yeah.
whole separate
Absolutely.
wow, that had to be tough.
That's a whole nother podcast.
Whole nother podcast. That's right. That's right. Now, do you still work as a sexual assault nurse, or do you still do something in that world, or not really?
No, I don't. I mean, as ER nurses, we
Of
all kind of
course.
do,
Yeah.
to
Yeah.
some degree. But no, when I left Europe, I got a gig as a trauma nurse on the civilian side, and
Good.
have slowly just gotten more and more towards education.
Got it. Gotcha. Gotcha.
Yeah.
And what made you decide to get into education after your time in the emergency? What made you decide that you wanted to teach and do that kind of thing?
It was the forensic nurse instructor role. getting to work with people one on one, and especially the newer nurses, and see the light bulb come on or
Yeah.
be able to connect with somebody. Um,
Isn't that
it,
a cool thing?
it is so cool. Yes.
Yeah.
I still, yeah.
Yeah, it's really nice. That's one of the things I love about teaching is like you can see the little light bulb coming on. You're like, oh, they're finally getting it. That's awesome.
Yes. Yes.
So, right?
I mean, just this week, something as simple as an ACLS class where someone comes back and says, I've taken this 12 times in my career and I have never understood that way. That's cool.
How many that happened? I feel like that happens a lot in ACLS. Like people take ACLS a lot and just kind of go through the motions and they're like blah blah blah. Um, but then for some reason, an instructor just hits it just right. I remember I taken ACLS, I don't know, probably 2 or 3 times. And then I took it once with a paramedic, and it was a really, really small class. And he taught it, he didn't do any of the PowerPoints, he didn't do any of that. He goes, "We're just gonna have a conversation. We're gonna have a conversation, and we're gonna talk about all the things." And
Oh,
it
I
was
love that.
the best ACLS class I've ever taken. We literally just sat at a table. I think there were 3 or 4 of us and just had a conversation about all the meds and why this med, not this med, and why this med, and why this med is the right one for, going down this algorithm. And then the scenarios were very much like teaching scenarios. Like, he's like, I know you guys are all nurses. Let me just show you a little bit about, something a little different. And it was one of the best ACLS courses to this day I've ever taken. So
That's awesome.
yeah, I love it when you can just make it hit just right. And part of it
Right.
is probably got to be you probably got to be in the right mindset of, where you have the right questions or the right questions to ask. Um,
Yeah.
but when it works, man, that's kind of cool to see the light bulbs come on.
That is so cool.
What's your favorite course to teach?
Ah, I'm
It's a
I'm an
tough one.
ENA fan, so it's probably TNCC or EMPC. Actually, probably EMPC. I love pediatrics too.
Yeah. I haven't got my EMPC instructor yet. I need to. Just updated the course. I took the course with Shantae, and she was
Yay!
phenomenal. Um, but now I got to take the instructor course. I've been a TNCC instructor for, I don't know, 2 years, 3 years, something like that. Again, I lost it. I let it lapse, so I had to go back and do it again. Um, but the next one I got to do is EMPC. So,
Yeah, that's an
but
easy bridge,
yeah, yeah, it's super. They make it super easy. So,
right? Yeah.
all right, let's get a little bit into your days as an ER nurse and talk a little bit about that. In your time as an ER nurse, tell me about a patient that changed the way you practice. A patient that, you know, you learned something from and that just changed the whole way you practice.
Isn't that so many of our patients?
Really can be.
Man, yeah. I find myself going back to a geriatric patient who she was just a diabetic. She was sick. Her foot was in really bad shape. She was probably my first patient with gangrene, um, but she was lonely, and she just needed someone to talk to and to hold her hand. Um, she knew the things she needed to do to care for herself, but I think she needed to feel like somebody else cared enough for her to do them. Does
Mm.
that make sense?
That totally makes sense. That totally makes
Yeah.
sense. It's hard to make that kind of connection in the emergency department when we're like, we're usually so run, run, run. But
Yeah.
yeah,
I was a night nurse, and I think you had a little bit more time with your patients. And being new, you don't know how to break away. You know, when they do talk to you or hold your hand, you're sitting there, and you might in the back of your mind be like, "Ah, I gotta go. I've got to go do X, Y, and Z for the
yeah,
next person."
but you don't know how to be
Um,
like, you don't know how to cut it off and not be rude,
yeah.
right?
Yes. Yes.
Yeah.
Yeah.
And one of the things that I think is kind of cool about my role now, I'm working as a house supervisor now. And one of the cool things is I don't have a patient assignment. Like, I mean, I have assignment of the unit, of course, of the building, of course, but, um, like, I don't have a patient care assignment where I'm like, "Ooh, I gotta go. I gotta go give this med." Like, so I get to be the one that gets to kinda sit and talk and can,
Oh.
manage that time, and I had an opportunity to do that last night. We had a guy who's very, very sick, and I was talking to the family. I was talking to him and talking to the family. We had a rapid response, so of course everyone shows up and we're doing all the things, and when it was all kinda said and done, I was like, "Okay." I was talking to the wife. I kinda switched gears and started talking to the wife, and I said, "Okay, here's kinda what we're doing. Here's why we're doing it." And she's like, "I understand all this. I'm a nurse." And I was like, "Oh, well, okay then.
Okay.
Okay then." And then the patient goes, "Yeah, I'm a nurse too." And I was like, "Oh my gosh, I had no idea." I go, "I won't hold that against you." And he kinda chuckled, and he said, he goes, "The bad thing about being a nurse is," he goes, "I know what's going on." And I was like,
Well, yeah.
and then he kinda went off and went to CT and did his thing, and the wife was just kinda sitting in there, and that's when the tears came. And,
Oh.
we just kinda sat there and had a conversation, and, just kinda sat there and held her hand, had a conversation. And, like, his nurse, he wouldn't have had a chance to do that. His nurse wouldn't have had a
Yeah.
chance to do that. Then, the other nurses on the unit, once the rapid was done, they were, of course, were all like, cockroaches when you turn the light on, they're gone.
Right,
Uh,
right.
but I was like, I got a little bit of time. So we kind of just sat there and talked and visited for a little while. And, next thing you know, they come rolling back from CT. And I was like, oh, geez, I was going to go down to CT and check on you guys and never got out. And they were like, "Oh, we're good." So, but being able to
Oh,
just make that connection sometimes in the ER is hard, but it makes a really big difference.
yeah. It's
So,
amazing how just touching someone or holding their hand can help you make that connection so fast.
and one of the things I was thinking about, and I was thinking about this with a new nurse, is like, how do you teach that to a new nurse? And as an instructor, that'd be a good question for you. It's like, how do you teach that? Is it something that they innately have to have, do you think? Or is it teachable? Or is it, learn by example? Is it, how do you think how do we how do we teach the new generation of nurses that's what makes you a good nurse? That's the difference between a good nurse and somebody who can just get all the shit done and get all the, check all the boxes and
Right.
do
Right.
all the tasks,
I don't that's the whole nature versus nurture debate, right?
right?
I don't know. I don't know. I do think, there's an element of you got it or you don't, but
There's a little bit of that.
I've seen so many that you're like, "Oh, this person's just not they're not plugged in. They're not getting it." And, they surprised me.
Yeah. Yeah. One of the things I've found is you can tell a difference between the nurses who really care for their patients and who are just like, whatever. Like,
You feel it.
you feel the difference.
Yeah.
And even, you see it in other people, whether you wanna see it or not. And, man, it's sometimes kinda tough. It's kinda tough to you're like, "Ugh, gosh," you're like this close to being a really good nurse. Like, skill wise, sure, you're great. That's fine. But like,
Yeah.
I don't care as much about that. Like that, I don't know. It's just not my thing. So, but
Yeah.
yes,
Do you think you can teach that?
I think you can model it. I think you can model it. I think you can show it. I think a good example. I think is a good example. I don't know. So I remember when I was working PRN, I was working PRN in an ER, and I was working full time. I think I was working full time for the state at the time in like a more admin role. And I was working a shift in the ER, and I was just kind of doing my thing. I was, taking care of, I would often get assigned to what we call the metabolic encephalopic unit. So it's the
Wow.
intoxicant, the drunk tank, essentially. Um,
Yeah. Yeah.
and, most of the staff who worked there all the time, they were tired of that area. And I was like, I love it. I can take really good care of some drunk people. That'd be just fine. Um, and sure enough, so I'm there and I was there with a tech, and she was a tech who was in nursing school. And I remember her being just shitty to one of the patients.
Oh, oh.
And I was like, what are you doing? And
Yeah.
you sound like a salty old ER nurse. And she just looked at me and she's like, oh, okay. And I go, no, that wasn't a compliment. Like that, I don't know if you're
Oh,
taking this as a compliment. And it wasn't a compliment. It was very much not a compliment. And I go, these people, people love these people. Like somebody loves that guy. And I know he's a pain in the ass. And I know
yeah.
he's there and making your life miserable, but somebody loves that guy. And if you just kind of remember to treat people like somebody loves them, somebody sees something in them, I think that goes a really long way. And she just kind of looked at me like, oh, and I think it was kind of sobering to her, but I think she'd seen that behavior modeled of just kind of like, whatever. And I was like, "No, that's not what we're gonna do here." I go, "This isn't personal. They don't know you. They don't know your mom. They don't, they don't know anything about you, and none of this means anything. So that even he can call you all the names and call you all the whatever. It doesn't matter.
Yeah.
Like,
Yeah.
just treat them well. Just treat them well."
You nailed it. And even if
So
somebody didn't love them, we should love them in the moment they're with us.
yeah, I mean, at least be if nothing else, just be kind. I mean, there's no reason
Human.
not to be. Yeah, and
Yes.
now don't get me wrong. I mean, I can be if we're gonna, I'm going to make sure that I keep me and everybody else safe. But it's certainly, there's a lot of chance to give people a lot more compassion than maybe that we always do. So,
Yeah.
but
Agreed.
anyways,
Oh, yeah.
tell me about a patient that touched your heart, a patient that you'll never forget.
Probably, I mean, I've had a lot of them too, patients and their family, but probably an older gentleman in San Antonio who is a veteran. I mean, being a veteran, you have a bond anyway, but just wanting to tell his story.
Yeah.
Yeah. He didn't have a ride home. This guy ended up being a frequent friend. And there were more than one occasion, maybe a couple of times where, I'd give him a ride home because you find him sitting on the bench outside the ER when you go to leave.
Okay. Not recommended, by
Yeah.
the way, but
No, no,
not recommended for the average nurse.
no.
Don't.
It's definitely a different culture in the military and with the veterans. That's probably still not safe at all, but,
Yeah.
yeah.
Yeah. So
Oh,
I and that's probably a thing. I worked at the VA for a while, and one of the things, the camaraderie amongst the military, it's just another level. It's just different. Oh, how was your experience being a nurse in the military? What was that like? That has to be a little bit different.
I miss it, uh, desperately some days. I think it was a blessing that maybe I didn't realize in the moment. There's definitely challenges. When I first showed up to my first assignment in San Antonio at Lackland, I will never forget the major who was she was going to be my direct supervisor. Who I walked in civilian clothes. Hi, I'm, you know, Lieutenant, and my other name. And she said, "Oh," and looked me up and down and said, "You're the nurse we didn't want," and walked away from me.
Oh,
And that was how it started.
wow.
And I realized later they didn't take new nurses in the ER or to be trauma nurses, and I had only been a nurse for a year. So there was a big push to not have a newer nurse. It's not like the civilian world where we take GNs, but you very quickly, like you've already mentioned, the camaraderie is just, I was surrounded by some of the best people, all amazing. And the teamwork is just outstanding. And I mean, you talk about have each other's back at work and outside of work. I'd not experienced that since in the civilian world.
That's kind of a cool thing. Like, that's a cool thing to have that kinda teamwork and that sense of unity with a team. You don't get that very often.
No, no, it was
So
amazing.
so
Yeah.
so when you were in the military, you were active duty for how long?
7 years.
Okay, that's a while.
Yeah. Yeah.
That's a while. And
Um,
how was that transition your first when you first got out and you went back to the civilian world of nursing and no longer are you there as a military nurse and now you're there with the civilians. How is that transition?
that was hard. It was really hard. I don't think I recognized that it was transitional struggles when I first got out. I thought it was just, I moved from Europe to Texas and I changed jobs and, you're meeting new people. But in the military, everybody moves every 2 years. So you're very quickly welcomed by your team and, you get your family.
Yeah.
And it's not like that in the civilian world. I mean, you really got to earn your credibility and, uh, I mean, it's political in the military too, but there's just a lot more. I don't know. It's try and think of the right word for it. It was really hard. Yeah. I'm
I bet
definitely acclimated to the civilian world now, but it took a while.
I can imagine going from military caring mostly for military and or military families to the general public. That had to be a transition. That had to be a big difference.
Yes. Yeah, definitely.
So
I mean,
I
yeah.
I can only imagine.
I mean, in the military, nurses are officers. So there's a whole different element of respect that comes with your position as a nurse. You can have nurses that outrank physicians.
Mm.
And in the civilian world, it's absolutely not like that.
So if you're a nurse who outranks the physician, how does that play into the dynamic of, the physician versus nurse versus officer versus higher ranking officer? That had to be a little different. That had to be a little weird.
I don't ever remember it being a challenge because there's
It
just,
just
again, that
is.
camaraderie where nurses and physicians work as well together as the nurses did with our medics. Um,
Yeah, like
yeah,
everyone what I how I think it is, and I you tell me how I think it is I think it's, they're all one team and it very much gears itself towards that. Like we're all a team regardless what our role is.
right. And you respect the role and where someone's coming from in their profession outside of here's our rank and our position or structure in the military.
Gotcha,
Yeah.
gotcha.
Yeah.
Yeah, it's always that kind of weird thing where you're like going, okay, you're a nurse, but you're a higher ranking officer than the physician. And yeah,
Right.
I sometimes see this now in the house supervisor role where we had a doctor who was like, this doctor is like, well, hey, I'm not comfortable taking, said she wasn't comfortable taking a patient that we were going to be admitting. And she's like, well, I'm not comfortable taking this patient. And I go, real sorry about that, but you're taking the patient. And she's like, do you get to tell me that? And I'm like, yeah, yeah, I do.
Yeah, pretty
I
much.
sure do. Yep, yep. I go, you may be the physician in charge, and you're certainly in charge of patient care, but I'm the administrator on duty, and this is what we're doing. So uh, if you want to call the CMO, we can give him a call. And this is at like midnight. And I go, you want to give him a call? We can
Oh,
give him a call.
no.
Um, yeah, here's what he's going to tell you. This is what we're doing.
Right.
And she was like, no, no, it's fine. It's fine. I was like, I go, not trying to be an asshole, but this is what we're doing.
Right,
And
right.
and she was like, well, okay. She's like, well, I'm going to call,
Alright, alright.
she's like, well, I'm going to call the CMO in the morning. I'm like, give him a call. Give him a call. I was
Did
like,
she?
I'll call him first. So, she did call him first. She did call him first. And I talked to the CMO and said, hey, I go, I hope I didn't come across as a little bit of a jerk, but I might have. I go, um, she was very upset and I was kind of like, forcing the point, going, "You don't have a choice, ma'am. This is what we're doing." And he goes, "Totally appropriate." She, we had a patient who was very sick, and she's like, "This and really needed to be somewhere other than our hospital." And she's like, "Well, I'm not comfortable taking care of this patient." I'm like, "That's great. He's ours. He's here. He's in our house. And I'm not going to leave him in the ER because you're not comfortable taking care of him in the ICU." I'm like,
Right.
you're an intensivist for God's sakes. Like, take the
Oh
patient."
my goodness.
So it was
Wow.
an interesting conversation to have where I was like, "No, real sorry you're not comfortable. Here,
Right, right.
here's what we're doing." So one of the things,
Oh,
one of the things I don't want to get a chance to not talk about is I want to talk a little bit about your research, and you kind of alluded to this a little bit um, when you talked about workplace violence was a focus of yours. You recently did your doctoral research, and I'd like for you to tell us just a little bit about it. Tell us a little bit of what you studied, what you found, and share a little bit of that with us if you could.
yeah, absolutely. So my project was focused on how do we mitigate issues of workplace violence? We know as ER nurses, we're going to face them. We know there's lots of legislative efforts to help curb violence, but it's not going away. So as I was doing literature searches, I found that there are not many pieces of published research that tell us how to address it. There's lots of research that defines what workplace violence is or gives you statistics to say how often it's happening,
Yeah.
but not tools for
Yeah.
mitigating it.
Like, then
Um,
what? Yeah.
right, right. And so before moving to central education, I was over in ER. And there were so many times where something would happen and I didn't know personally what to do. I'm in leadership. I have all the contacts and I don't know how to handle this. Like I know how to file the TAPS report. I can go and immediately help my staff, but then what if I'm not there? And then you get that where you're wearing the cape and you can't do that. And there's nothing good about wearing the cape for your department or your staff because you can't be there all the time and they need to be able to take care of themselves and we need something for continuity. Um, so
When you
that got me to looking and there just isn't anything.
when you say wearing the cape, what do you mean by that? Because I think that's kind of a I think I know what you mean, but I want to make sure everyone else knows what you mean.
We want to be our staff's hero. We want to make sure that we're taking care of everybody. Like as an ER leader, and I'm sure you've experienced this, but in the wake of COVID, especially, like you can't sleep at night. You're worried about your staff. Um, so I don't want to be laying in bed worried about my staff getting hit or some kind of acts of violence and them needing me to come in and help mitigate whatever is going on. They should be able to address it and be safe whether I'm there or not. So I don't want to be the hero. And we shouldn't all rely on one hero.
Right.
Yeah. So that got me to researching it, and there are just not many pieces of published literature about how to mitigate it. So that led me to my project, which was measuring the effects of a workplace violence algorithm in an emergency department setting. Um, that was the gist of it. So really what I wanted was a tool that the staff could use that gave them yes or no.
If this, then that.
If this happens, then do this. An algorithm that could be in place.
Perfect. So I'm assuming you did this based on what your organization did to address workplace violence. Um, and then gave them an algorithm of, okay, then do this, like kind of then almost like a little recipe for this is how we address it here at the organization. Correct?
Yes. Yeah. So it was a collaborative effort. And we didn't change any policies for this project. We took policies and procedures that were already in place, and all we did was put them into the escalation algorithm. But as we were compiling this, which I thought would be, let's just get everybody together and put it on paper, you found all of this ambiguity in the policies.
It's
Yeah.
sometimes maybe this, sometimes maybe that.
Right, right. And you don't want to be super prescriptive with your policies and procedures because then you pigeonhole yourself into having to do something. Um, but for instance, you might have known that security needed to be called for somebody who is completely out of control. But who's going to call security and what is security's response going to do? And depending on who was on and who was security for that day, that response might look different.
Mm. There's a lot of moving factors and a lot of things a lot of potential variables.
Yes. Yeah, absolutely. Um,
So,
so as we put this all together into the escalation algorithm, um, then we educated, well, to educate staff on this, we had to make sure that they had re-education on what is workplace violence. So we did some huddles, we educated the staff on what workplace violence is, the four types of workplace violence, which my organization actually classifies as five types. You have your violence that is perpetrated by a criminal, violence that's perpetrated by a patient, to a patient, lateral violence, or somebody who has a personal relationship with staff. So we re-educated on what is it, what does it look like, which it's been all over the news lately. And in the last year, there's been so many injuries, stabbings, shootings.
it's kinda
We
crazy.
all recognize that. It is. It is out of control. We recognize it when somebody's hitting someone or when somebody's using a weapon, but I don't
Yeah.
think that we recognize it when somebody's just escalating. Like you kind of become numb.
Yeah. When I
You
mean,
know?
just the verbal assaults that we have to deal with every day that we're like and that shouldn't be something we have to deal with.
Right. Right. And then
So,
it's a cycle we perpetuate because we make new nurses prove themselves and we don't allow them to express their feelings and validate them when something bad or negative happens in the department and yada yada. Yeah.
yeah. We're like, "Oh, yeah. Yeah. That sometimes happens here." We're just like,
Yeah. Yeah. I'm sorry that happened. Okay, go back to your next patient.
"Yep. Absolutely. 100%." So how did the
Yeah.
algorithm work out? So what was the tell us a little bit about your study. So how did you do like a before and after? Tell me a little bit about how this all kind of played out.
Yeah. So I ended up finding a climate survey scale that Hutchinson wrote, and it combines three different types of surveys. It has a workplace violence survey, like a climate survey, and an incivility survey for your unit. And it compiled them all together with a 10 question survey that is a validated tool. And so we used that, administered that to the ER staff, all levels, not just nurses, anybody who was in the ER got their scores on a 1 to 5 Likert scale, everything from strongly disagree to strongly agree. And then we did the post survey. And the questions would ask things like, my organization supports me if there's an instance of workplace violence, or my colleagues recognize
Mhm.
workplace violence. Yeah, I could read some of the questions to be a little more accurate. My organization makes it a priority to prevent workplace violence. That's one of the questions on there.
Okay.
So, got this tool together, got the algorithm together, did some education, and then had everybody, before they got their education, do this survey on the 1 to 5 Likert scale. And then we did a post survey after education. And again, 6 weeks later, would love to do this over a much longer term, with the goal being that we A, decrease turnover, and B, increase the staff's perception of the organization supporting them in the wake of workplace violence or recognizing um,
I
efforts
got
that need to be made.
I got to tell you that makes a big difference because if you feel like if you feel like if you get punched at work or assaulted at work or yeah, in any way and you feel like the organization doesn't give a shit, like you're going to be gone. And you should be because if the organization doesn't care, why stick around? So,
Absolutely. Yeah.
So you did
Uh,
the before and after, you did the pre-survey and the post-survey. And then what was the education in between? What was that? What did that kind of look like? Was it something different than the typical workplace violence awareness training that they got at work anyway?
It was a little different. I mean, the verbiage was probably the classic. This is workplace violence, recognizing that someone cussing at you is workplace violence. I did focus a little bit on incivility. Gave them at least, I want to say, like 2 minutes of here's what incivility that is workplace violence looks like. And then I had the CNO of the organization, the director of the ER, and the director of security each do a little video of themselves and their thoughts on workplace violence and basically expressing to the staff how they wanted to support them. And that was captured with the education.
Nice.
Yeah.
And then how did it go from the pre-education to the post-education? Did you see a big change?
Oh, I bombed the whole project. I felt like at the time was a complete disaster. Um,
Okay.
yeah, we definitely had answers that were statistically significant. We used a double-tailed t-test and a Spearman's correlation. And question number 2 on the survey was, my organization has established a safe and respectful workplace. And we had statistical significance that went the opposite direction. So when we started this, 85% of the staff would have either strongly agreed, um, either agreed or strongly agreed. When we ended this, only 45% of the staff strongly agreed or agreed. I know. Yeah.
All right. Wow. What happened? Like, how does that like, I'm not a smart man. I don't know. Like, how does, like, you're like, okay, we're going to give you some education and show you what we're doing. And then, yeah, to have less people be like, oh yeah, like the complete opposite. I, I can't even imagine how that had to feel for you as a researcher being like, this is not at all. But one of the things that
Yeah.
I've learned from Lisa Wolf is the data is the data. Whatever it is, no matter how you feel about it, it's still the data.
Right, right. I was very devastated for a little while. I think I actually kind of mourned my project. Like, this didn't work out the way I wanted it to. I'm trying to help here. Um, I'm not in that state of mind anymore. It's a good project. It gave us information we didn't have before, and I have a couple of hypotheses about why it turned out this way.
Uh,
Um,
I would love to hear it because I can't even imagine being like, you're sitting there going, okay, this is all like everything is geared to improve all these things. And then when they didn't, I'm sure you're like,
yeah, yeah,
What do you think happened?
devastating.
I can't even imagine.
I I mean, and of course, it's only speculation because you can't prove without another study conclusively why your results went this way. But I have 2 theories. My first theory is, we don't, ER nurses, we don't recognize workplace violence. We're kind of numb to what we are doing in the department. We are numb to the incivility. OSHA talks about how, of all the workplace violence incidents in the United States, less than 20% of workplace injuries are felt by healthcare workers, but over 50% of assaults are felt by healthcare workers. And
Hmm.
they go on to say how it's just so underreported. I don't think we're recognizing it. Yeah.
That
So one theory
100%.
is that we gave them education and then all of a sudden they recognized it. You start looking around and you're like, oh, you're kind of being an asshole. That falls along that. I've reported you and nothing's happening about it. So my organization must not value what I'm saying.
Oh,
Or this patient threw a table at me and I reported it and no one did anything. Like, you start to see things in a way that you weren't seeing them before. So
uh,
education. That could be one thing.
Yeah.
Um, that's the way I tend to lean with this, meaning that we need more attention so that we recognize it.
Well,
Uh,
holy cow. So all the time you put into your study, you get your results back and they're not what you expected. Not but yeah, I think your hypothesis is correct, is like, just the fact that ER nurses don't recognize what is workplace violence and what it means and what, you know, so I guess I'm not surprised that the scores may have went down a little bit.
I mean, maybe the wording of saying ER nurses don't recognize it isn't accurate because I absolutely think that ER nurses know somebody who's going to be violent without courses like CPI. Like we know
Yeah.
there's just it's like being in that violent relationship where so many things just become normal.
Yeah. No,
Yeah.
yeah, we've kind of normalized it where we're just kind of like, yeah, okay.
Yeah. Yeah.
So speaking, you mentioned courses like CPI. What are your thoughts on courses like CPI? Or have you found a course like that you like, that you think is, not that we're endorsing anything or anything like that here on the podcast, but like something that you're like, okay, this maybe makes a difference.
I haven't experienced
Yeah.
something that I'm a huge fan of. I mean, CPI has some good elements. I would have said if you'd asked me last year, they need to have a healthcare focus. I know they have come out with one that is more healthcare focused. I haven't seen all of the curriculum that goes with it. Um,
Which one is that? I haven't seen one that
it's actually
you remember.
CPI, like their new course is for healthcare. Um, I want to say the
Huh.
book came out in
Interesting.
January.
Oh, okay. I'm gonna have to keep an eye out for it because I'm not a huge fan of
Mm-mm.
CPI. Like I think CPI probably works for like I don't even know.
Right.
I think it works for maybe I don't know, social workers maybe. I don't even know. I haven't found one that I thought really was geared for nurses, and I would love to create that. I would love to create that one that's for nurses, by nurses, that, has, the elements of, the de-escalation, along with the physical moves that you need to do to keep yourself safe. I think I've been through I don't even know how many of those courses, and I found different pieces that I thought worked pretty well. Um, but the hard part is, and the conversation I always have with Lisa Wolf is like, how do we prove that these make a difference? And how do we prove, like, if we teach CPI and we teach you, how to do these moves to release a grab, to avoid a strike, how do we say those really work if you may not ever have a chance to do those things? Like, it's hard to say, like, these are true. It's hard to really kind of prove that these are
Yeah,
effective.
I agree. And I mean, I like the de-escalation piece of CPI, teaching that. I think verbal judo is something that everybody should know, especially
Yep,
in the ER.
yep,
But I also am not a huge fan
for
of
sure.
zero tolerance policies. I really think that that needs to go away. I love that legislation is has grabbed a hold of that and we're using it for a push, but especially in ER nursing, we can't have zero tolerance. And so if we bring our baby nurses in and we
I
teach them, we're going to have zero tolerance, but we're not really going to do anything when something happens because of IMTALA or because of this. I mean, we're just sending mixed signals.
Oh my gosh, 100%. When facilities say, "Yeah, we have a zero tolerance policy," I was like, "Okay, then do they
Right?
leave?
Are you kicking
Like,
them out?
do they get are we gonna kick them out? Because well, part of me would be absolutely in favor of that. The other part of me is like, this asshole still needs
Right.
treatment."
Right. Yeah, no, I mean, we have a moral and professional obligation to take care of somebody when they're sick, and sometimes sick people lash out verbally or physically. Um, yeah, nah.
Ah, I I gotta tell you. You want to write a paper. There's your paper idea. There's your journal article idea is how do you balance a zero tolerance policy with the needs of the patient? Because I don't know
Well,
that
you
you
start
can.
by not calling it zero tolerance because we have to tolerate some. Yeah.
And that's an unpopular thing to
Yes.
say, but it's 100% true. Because the reality is, it's not zero tolerance policy, by any means.
Yeah, so
So,
if you were chief operating officer of your hospital, what would you do?
oh god, good question. Um, yeah, I certainly would get rid of the zero tolerance policy wording. Um, but like, what do you replace that with? That sounds acceptable to the nurses, yet lets patients know that we're not going to be their punching bag. We're not going to tolerate their abuse. Um, I don't know. I don't know. That's a tough question. That's I'm supposed to be the one asking the hard questions, not you. But you're right. What do you do? Because the reality is you can't. I mean, it's situation
Right,
dependent.
right,
So
right.
if we're gonna have to fight you
Yeah.
to keep you safe, what's the best thing to do? Do we fight you to keep you safe, or do we just tell you, hey, good luck? Go out in the world. You're an adult. You get to make bad choices. Um, and I don't know what the right answer is. I think we have a professional duty to take care of those who are in need. But sometimes it's really hard to tell when there's that where is that
Right,
line?
right. I think you nailed it with the
So
overcorrection, and that's what the zero tolerance is. Maybe we should overcorrect the other way where we say we 100% support our staff being safe rather than we have zero tolerance.
that and maybe that's the verbiage change that needs to happen. I don't even know. I'm not sure because I'll be honest with you. I you know as an ER nurse, as long as I've been doing it, I've never felt. I don't know. I guess I felt that there were some organizations that got it and supported, but I think most were concerned less about the nurse and more about litigation
And perceptions. Yeah.
and perceptions. And there's very much a difference between and you've probably seen this and when you work in either a county or a government hospital where in the VA there were some people who really felt like it's okay to treat the patients however you want to treat them because
Yeah.
where else are they going to
Right.
go? Like you're stuck with us. You're not going anywhere else. We're all you got. You got us. We got you. And then, you have no choice there. But what they're realizing in the VA certainly has done this as well is they've realized people have a choice, and if people choose not to go to the VA, then the VA is not going to be a thing,
Right.
right? Like then it's going to be a managed care something entity, right? Like it's not going to be a facility.
Right.
Um, but yeah, I don't know. So I've seen that. I've seen the people who are like, well, it doesn't matter. You're not going anywhere else. And then I've seen other hospitals that are like, we very much want you to choose us. That are, you know, your hospital's a good example where they want to be, they want to be the one that people choose and people have choice and they're going to do whatever they can to try to make it as patient centric as possible. Um, and I think sometimes that might be at the cost of being nurse centric.
Agreed. I completely agree with you.
I don't know. What are your
Yeah.
thoughts?
No, I completely agree. Which
So,
there's legislation that's potentially going to help with this, but I don't know how much it's going to be a facade. I mean, you get all these House bills and Senate bills that say, okay, you have to have a committee that's working on workplace violence and somebody that's overseeing our efforts and a way to report. But what about the follow up? And what about
yeah,
displaying openly your metrics? Um, yeah,
yeah.
I don't know.
It's such a tough such a tough nut to crack. It's just hard to. There's so much to it that's hard to kind of get it all figured out.
I
I don't
just
even know.
saw actually share with you a survey that I saw. There was a survey published in September of last year. Press Ganey's National Database for Nursing Quality Indicators, so the NDNQI, unveiled staggering statistics for this Press Ganey survey. It says more than 2 nursing personnel are assaulted every hour or were assaulted every hour in Q2 of 22, which equates to 57 assaults per day, 1,739 assaults per month, and 5,217 assaults per quarter. That's insane.
That is insane. And I mean, I'm trying to think. It's a little harder for me because I'm not in the ER every day, but certainly if something's going poorly, I'm there. Um, but I every day, like right now, a nurse somewhere is getting either verbally or physically assaulted. I mean, it's
Yeah. I-
and I just don't know the answers on how do we how do we help that? How do we you know limit uh, uh, how do we limit that to make sure that they're as safe as possible and they want to be where they are? And that's one of the things because you know nurses will absolutely leave.
They will and they are. Turnover is staggering, and
They
COVID
are.
didn't help that any.
Nope, not
Yeah.
at all.
Um,
Not at all.
I
So
think I think it ties in with all the push for a just culture. We need shared accountability, which starts with education.
so what did you learn from your study? Like what were your big takeaways?
Oh, I learned a lot. Uh, the yeah,
You learned the data is not always what you want the data to be.
absolutely. Yeah, putting it on paper obviously doesn't make always the difference, but buy-in. You need buy-in, leadership buy-in. If your leadership is not bought in to the fact that there is a problem, then all the solutions in the world aren't going to make a difference.
That's a good point.
Um,
That's a really good point.
yeah, and I think I learned more just how much we accept um, as a culture of nurses. We accept as the norm, and we're passing that on to our baby nurses. Um, how much we tolerate through this process. There was a huge rise of reports at my facility. You educate them on it.
Really?
Yes, the reports went up, and our workplace violence committee um, membership quadrupled during the time of this. Like it,
Okay. Those are good
yes, no,
things.
it's staggering, like really good. And leadership definitely got more vested, and let's come up with some actions and initiatives, every month that we can do and report out what we're doing. Um, but you don't know what you don't know, and the more you know and the more you hear about it, the more you feel like you're really just drowning in it.
Yeah, I'm sure. What did your what were did your organization process the results of your study? Did they review the study and be like, yeah, I'm sure they reviewed the study and were like, okay,
Yeah,
what were their
it got
thoughts?
shared on a system level, so it rolls up to a system workplace violence committee, which rolls into the safety committee. They're very bought in to making changes. Um, oh, what I didn't tell you, so I told you I thought there were 2 reasons that our results were so staggering. The
Oh yeah,
first
yeah.
one was my perception and my hypothesis was just being grossly undereducated. But the second one was during the time that I was doing this project, we actually had a guy who was a patient. Had He had just a week before put a physician at a hospital a mile down the road in the ICU. He was a patient in our ER, lost his mind, and said as he was leaving that he was going to get a weapon and was going to come back and shoot everybody in the ER. It,
Oh my
yes.
gosh.
He ultimately, they pressed charges. Our hospital did for terroristic threats. He went to jail. He was gone for a few months. But you can only imagine, like, we had to have EAP in the department. We had police and security and all kinds of emergency lockdown procedures were instituted. And that
Holy
happened
cow.
while I was doing this study. So that also,
Oh, talk about skewing the
absolutely.
results. Like, I'm sure everybody was like, okay, where's that survey? I'm
I
going to go do it
absolutely
right
do not
now.
feel safe here. Right, right. Yeah,
Holy cow. Wow.
because that could have skewed it.
100% it skewed
Yeah.
it. The one last question I have to ask, because I get heat if I don't ask this question, is a question called
You're making
three
me
things,
nervous.
where it's it's a tough one. It's a tough one. Um, so the question is, what are three things an emergency nurse should always remember, and what are three things they can just forget?
Okay. Let's see. 3 things you should remember. How to make a margarita or a mojito if that's your preference. That's definitely my number 1. Um, oh man, Kevin, it's on the spot. I need a second. Ah,
It's a tough one.
you got to remember to love each other, take care of your colleagues, have each other's back.
Have you?
I just taught BLS, so I gotta say, like, if you don't have an airway, do your 30 compressions and pause for your 2 breaths. That's gotta be my number 3. Um, I'll come up with something great as soon as we're off the call.
Of course,
Yeah.
yeah. You'll be laying in bed at night and go, wait, hold on.
Um, 3 things you can forget. Well, definitely forget the white scrubs and the white shoes. Yeah, forget it.
Yeah, yeah.
Yeah,
No, can't do white. Can't
no.
do white.
Um
My panties show right through it. It's terrible.
uh, since we're on the workplace violence, I mean, uh, you have to be able to forget what people say that offend you or hurt you. You have to be able to leave that
Mm.
at the door. Um,
And sometimes it's tough.
yeah, absolutely.
So,
Um,
but yeah,
that probably should have been one of my remembers is remember your family because you got to take care of yourself to be able to take care of your family.
it's a good point. It's a good
Um,
point.
I'm trying to think if I had a room full of baby nurses right now, what would I tell them to forget? Forget your nursing care plan, especially if you're going in the ER. Who has a nursing care plan? Forget it.
Yeah, that's not really a thing. And I learned a whole new respect for the care plans, for baby nurses and for nursing students. Now, of course, in the ER, like we don't do that, but you learn as a when I did the clinical faculty, I was like, okay, I finally understand why we make them do this. Like, I finally get
Yeah.
it. Like, and it's just an exercise and kind of learning to think and learning to think like a nurse. And uh, it took a long time. Like,
I need that in
I
my
still
life.
feel dirty saying it. I still feel dirty saying it.
Yeah.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.
Anyways,
No.
so, well, this has been a lot of fun. I really appreciate you taking the time to do this with me, and I'm so glad we finally got it together and got you on. Um, and this has been a
Thank
lot
you.
of fun.
Thank you. I appreciate your everything you do. You shed a
Uh,
light on
oh,
nursing in general, which is much needed.
boy, I sure do try, and it's fun to do because I love to talk, and I get to talk to amazing people. So
Yeah.
it works out pretty well. So.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.